Yeah, and a lot of emergency medicine is very much hands-on. You can learn anything from a book, but until you've done that hands-on procedure, and a lot of students at the time didn't get that. So they came in at a bigger skill deficit than other people because they didn't have that chance to do those experiences, to do those procedures, to learn how to place an IV.
Yeah. Well, you're right. There's a few people that can look at a book and go, I can do that, and can do it. But most people are, have to do it. They have to see it up close,
I think that's
personal.
a part of being in this field, though, is I know for me, I struggle reading a book and doing it, but then seeing it and doing it, I'm like, okay, that's why I got into this field. That's why I excel pretty well in this field. Is can't read a book and just do.
Yeah.
I'd be a doctor by now.
I think the overwhelming majority of paramedics are visual learners. I think so. I think they really are.
Yeah, it's such a hands-on field too. Yeah. It's not academic. Like I feel like I'm not very academic.
Academias.
I think you are. You don't think?
I just don't think that you have to be highly intelligent to do emergency medicine. I feel like I see more pattern recognition.
No, don't sell yourself short, because I got to tell you this. I've been doing this a long time, and I'm not blowing smoke up your butt, because any time that I dealt with you on scene, I knew that you knew what you were doing.
It was all a farce.
It wasn't a farce. and I knew that you were one of the guys that if I had a question, I could ask you and probably get an answer if I didn't know it. So
maybe a legit answer, maybe not.
Yeah.
But I think
you can
like
BS just like anybody else.
Yeah.
That's the other part of the job.
Yeah, don't sell yourself.
You do fake it till you make it a lot in this field. And I think that's kind of true with anything. I think like you can get all the PowerPoints and all the knowledge and everything, but then doing actual things. The application is very different. Exactly. Yeah. And once you've done it for a year or two, I think you see patterns. You've seen the same patients. You can determine sick versus not sick, because the book will never teach you that, right? I mean, the ability to look at a patient and determine if they are really sick or if they're not is something you just have to see hundreds of patients before you really get a good.
And nursing school doesn't prepare you for emergency nursing. Nursing school is very much inpatient tailored. So when you get down into the ED, you're like, wait, what?
Yeah.
Like, first of all, I can do all of this. And then second of all, I'm supposed to do all of this, because it's very, very different.
Well, that's one of the problems with paramedic school, is that's all they tell you. I wish we had more like information on patients, like general patients in the hospital. I'm interested in some of those things, and how you treat those things. And you just don't get that, in paramedic school. You get emergency management.
Yeah, I mean, these are the things that are going to kill a patient quickly. You have to be very good at those things. But I mean, PA school is similar. It's general medicine. It does not train you to be an emergency medicine PA. That's something you either do a fellowship as a PA, or you just learn on your feet quickly or not. And some people, same with nursing probably too. You either learn it quickly or, you're not able to, and you end up going to something else.
And that's why the interpersonal is so important between EMS and nursing and physicians, and even just, med-surg nursing versus ICU nursing, because everyone is just so specialized in what they do. And there is going to be someone who does it better than you because they focus so much more on that. So for the most part, EMS will be better at emergently triaging than a standard ER nurse will, because they deal with it more.
Right.
They're going to just be better at that. So, when we get incidents from the field and they're like, this one is more sick, run with that. You can always change your mind later, but if this is what they tell you, run with that, and we can figure out the rest on the back end. But like an incident we had, and it was just very important that they were like, these are our sick ones, these ones are here, and it helped just do our triage even further better, because they had already done all the basic triage for us.
Last time I was here, we talked about Gestalt, and you can't teach that. You can't. And that's probably one of the hardest things that we do, is learning sick versus not sick. And there's those paramedics or EMTs or nurses or doctors or PAs or nurse practitioners that don't get it sometimes, and a lot. And those are the ones that you don't want to take care of you.
Well, I think even when I was a new EMT, I think I overstated my ability to determine not sick versus sick. I think that's something you have to have time in the field, and there's nothing that replaces seeing patient after patient after patient. It's not something you come out of school knowing how to do. You've got to see hundreds of patients before you can do that accurately. And I think the mistake new people make, new nurses or new paramedics or new EMTs, is you're like, oh, I can figure that out. It's like, have you seen thousands of patients yet? If you haven't, you probably are not able to make that determination.
Like nuances, like oh, this patient's slightly more diaphoretic, and then it's like, oh, this patient's not breathing super well, or it's like it's seeing those little tiny changes. You're like, all right, let's dig into this more.
Right. So yeah, sometimes it's about what they're not saying versus what they're saying.
Exactly.
And, and how they look clinically. Are they a little sweaty? Are they pale?
Not every chest pain's a heart attack, but that still doesn't mean they're not a PE.
Right. Well, we had a patient a couple weeks ago that their complaint was not very high acuity, but and a couple of the people on scene were like, they're blowing them off, but the fire paramedic and I are looking at this patient going, why is their respiratory rate 50?
Yeah.
And they're talking to us, and they don't look like they're having difficulty breathing, but it's like, why? Let's get a sugar on them just to see, maybe their sugar's like 1400 or whatever, and they still didn't present like very ill, but they were really sick.
Yeah.
And, thank God we got them to the hospital. And,
And sometimes normal vital signs don't speak to the whole picture either. Sometimes someone can have normal vitals, and there's only so much objective information we can get that doesn't replace that Gestalt. But I will say, I think sometimes that can lead you astray too. I mean, I've had Gestalt about patients, and I'm like, definitely not sick. We can send this one home, and that turned out not to be the case too. So I think sometimes you gotta take that with a grain of salt and realize that sometimes your Gestalt's not accurate either,
Well, we get that once in a while, from working in the field, where we'll go on a call and they'll go, well, I was just at the hospital.
Yep.
Let's take you back. You're really sick, They just discharged me. Really?
Yeah. I always tell patients, like, medicine is not 100% perfect. Your workup looks great. You look great. But if something changes or gets worse, you need to come back because our tests are all imperfect. We're all imperfect people trying to practice medicine. Yeah. And so if something changes, you need to come back.
Or all your tests are perfect. I had a patient, he sat for, unfortunately, 9 hours out in the waiting room, but had CT scan, chest x-ray, lab work done. Everything was great. We finally get him into a room and like, hey, the doc's going to come see you, discuss your results, and get you going. Me and another nurse look at his EKG, and we're like, that doesn't look good. Let's get a repeat. He's in a STEMI now. And we're like, we're glad you stayed.
Yeah, 100%.
So people can just, even, after 9 hours.
Yeah, some of those, the stuff is latent.
Yeah.
You don't see it.
He's like, well, I feel good enough to go home.
The symptoms start, or they can't put their finger on what's wrong. And, you may not see those changes for hours. And, thank God you were looking at it, because they're easy to blow off. People like that are easy to blow off.
Yeah.
Well, we get that bias of, seeing X amount of patients, everything's fine, they're safe to go home. And sometimes that lulls you into this feeling of, oh, no one's going to die today. But then you kind of get this idea that everybody's low acuity, and then somebody takes you by surprise. And then you get that sick patient, and then you're assuming everybody else is sick for the rest of the day, and that's kind of biases you in the other direction. You assume once I find a PE, I tend to assume my next 10 patients are also going to have a PE, And I think you just, we all have to recognize our bias kind of goes up and down, and we're imperfect, so you also have to check yourself too.
I think one of the big things I've always done is just, even though I might have that bias, I'm still going to offer the same checkup to you. I'm not gonna, because I do have that bias every now and then in my head, like, this is me, but I don't want to be that one provider that sends the guy that 9 hours later had the massive freaking STEMI and then dies at home. Yeah. And I was the one that was just like, oh, you're just having a panic attack, or this or that. And so for me, it's like, I have that bias, but I always try and push that bias to the side to at least give them my best 100% of the time to check all those boxes. You know,
we'll still do your EKG. We'll still get your troponin.
Oh yeah, 100%. Because A, you don't want to be that person.
Yeah.
And then B, like I don't want to have that on me too, like down the road. You know, like I messed up and thought this person was just BSing. So, you know, I might be in the ambulance rolling to this call, just being like, why is this? And then, you know, I'm gonna get there and I'm gonna put on my customer service face and ask them all the questions and make sure they get that 100%, because that's what they need, you know.
Well, and that's what the crews that come in really with that bias of this patient's low acuity. I can't believe we had to bring him in. Like it kind of throws up a red flag for me. Like, okay, this crew's expressing a lot of bias that this patient's non-emergent. I'm probably going to order a little bit more because I know they're putting some clouded glasses on me as I'm taking care of this patient. So I need to be a little more cautious and actually do a little bit more to make sure that this is nothing dangerous. You know, and sometimes it turns out it truly is nothing, and sometimes we actually catch something. You know, because we all see so many patients.
I'd much rather me to err on that side of caution of being nothing, because I can't imagine. I've had those ones where I erred on the side of caution of it being, you know, something, and then it turned out to be something even worse than what I thought it was, and I was just like, you know, man, I could have. Then my brain just, what if I said he could have gone home? This guy was complaining one time of pain right in between his shoulder blades, and that was it. And he was like, I don't know, I don't want to go back to work. And I'm like, he's just being a baby. Like, grow up and be an adult. It's pain in between your shoulder blades. Nope, aortic dissection all the way down to it dissected into his kidney. Like, huge, massive. Like, I don't even know how this guy's gonna, you know, walk out of here type of thing. And I could have just been like, oh, you're fine, bud, just get on out of here type of thing. But you know, the only thing that was really wrong with him was his pressure. That was like 280 over 140. And I was like, that's weird. Yeah.
Well, we were talking with Kosh last time that the highest liability in EMS is that refusal, where you're leaving a patient on scene. And I think if I was practicing as a paramedic now, I'd probably leave almost no one on scene, because I can think, what would I order in the ER now? And I probably would order something. I mean, a lot of patients need some objective data to prove that they're not dying, you know, and we need that objective information to really say that they're safe to go home. And then sometimes it's very hard just based on their appearance to make that determination until you have the negative troponin. You have the EKG that looks great, you know. Sometimes we need that information. Do you guys have, as we kind of close out this show, any advice for the new nurse, the new EMT, the new paramedic that you would want to convey?
Yeah, nurses don't date paramedics.
Mine's a paramedic too, okay, so.
Oh, yeah, she is. I'm just kidding.
My biggest thing is have the humility to know that you don't know something. Yeah. One of my favorite things to do with new nursing students I have is if I have an LVAD patient, for them to go in and take a blood pressure. Because if you come back and you tell me a number, I know I can't trust you.
Yeah, right.
And a lot of it is, and I prefer the ones who come running back out and they're like, I couldn't get anything. Cool, now we can talk about why you couldn't get anything. Like, it is okay to know what you don't know, but ask for help, seek that information. The only way you're ever going to learn is if you ask someone to teach you, and you're willing to be taught. Mm-hmm. I don't expect you to come out of nursing school knowing how to take care of every single patient, placing 18s with your eyes closed. No one comes out like that. Mm-hmm. You have to take the time to learn and to be taught and to be willing to be taught.
Mm-hmm.
I think that definitely never stop learning.
Yep.
I think is the biggest thing. Just when you think you know it all, there's always going to be somebody else there that's going to teach you something new.
Yeah.
And I even tell new medics as well when I'm teaching them, you can learn things from everything, regardless of what it is. If it's how not to do something or how to do something, learn. Like, if you see somebody doing something you don't like, well, then that's how you're not going to be a paramedic, you know. Learn from every kind of encounter that you have. Ask the questions, too. Don't be afraid to ask those questions. I'll come back to a doc afterwards and be like, do you feel like I did that right, you know? Have that humility to be like, look, I don't know what was going on. Can you help me? Because there's those people that are there to help you. And then when you do it right, be proud of yourself.
Mm-hmm.
Like, don't underestimate, like, There's a lot of times where, yes, it's my wife, but I've had other people tell me, like, you're a good paramedic, and I still doubt myself of being a good paramedic, but I've begun to be okay with hearing that. I feel like I'm okay with it now because I've been doing this for so long. Like, I can finally accept it. Like, oh, okay, maybe, I haven't, maybe I am a good paramedic. But when people give you the compliment, take it. Like, because maybe you did something that they didn't even think about, like, take those compliments, learn what you can, keep moving forward, ask the questions, never stop learning, though.
Yeah.
Definitely never stop learning.
Yeah, that's good. I would say if you're new, don't trust your Gestalt and take every patient extremely seriously, regardless of their complaint or regardless of your perceived silliness of why they called 911. Take every patient seriously, because unless you've been doing this for years and years and you've seen thousands of patients, you really can't trust your Gestalt. Especially as a new EMT, that's a mistake a lot of people make, and I made it a ton. You don't take the patients seriously that you should be taking seriously, and this is the job, right, is to take patients to the ER regardless of their complaint. They think something's going on, even if you don't. Do your due diligence, take their vital signs, get the 12 lead, check the blood sugar, and give an unbiased report to the hospital as best you can so that they can get the best possible care. Because until you've been doing this for a long time, you really don't have the Gestalt that you need to be able to say a patient's not dying.
I agree with all those things that you've said. I'm big about learning as well. I've said this before. New people should keep a journal. I think you should. I wish that I would have, because I'd like to know how many babies that I delivered that were male versus female, because I've delivered a bunch of them, 37 so far, and I'd like to know how many were boys and girls, how many were really sick and how many were good, those kind of things, how many crikes that I've done, the patients that I'd done them on and why I did them, those kind of things. I think that's, as I look back on it, that would be something I wish I'd have done. So I always say that. I always tell my new people, keep a journal. Keep up on everything. Learn all that you can. One of the things that we don't talk about a lot is be honest. Don't ever lie. Don't ever say something that or omit anything. Make your charts honest. If somebody asks you if you did that and you did it, you tell them. Come to if you screw up and you know it, be the first to say something about it. I think that's I don't know. I think that sometimes we come down on people so hard that they think it's better not to say anything, and it's not. It's better to say something. Be humble. Understand that you do make mistakes. You should make mistakes, but you should only make it once. Make one mistake. Not just one mistake, but make the mistake only once, and then learn from it. So.
And if you don't own up to it, you're probably going to make it again too. I mean, it's that ownership of, medicine is not perfect. We're all practicing it. Errors happen, and if you're not going to own up to it, you're probably not going to learn from it.
And you'll be found out.
Yeah.
And when you're found out, you may have had a good reputation, but your reputation will be burnt from then on.
And everyone kind of knows whose fault it is too. If you refuse to take ownership over a mistake in patient care or something that got omitted, everyone kind of knows whose fault it is. And if you don't take responsibility for it, it just looks bad on you. It doesn't, it looks better on you if you take full ownership. Like we've had, different situations with patients, and maybe it was a nursing error, maybe it was something I put in or ordered that was a mistake, but just take responsibility for it, because people are going to respect you more if you take responsibility for things.
I think you need to realize that it's a really hard job. It really is difficult. Dealing with people is really hard. especially when you're dealing with them on their worst days. I've said this before, Tracy, in one of the videos that we had, said we have the privilege of dealing with people on their worst days, and that's the way you should feel about it. It's a privilege that you're able to do that, and just some of those things to remember.
That's all really good advice. One thing I always try to tell, because I have a lot of new paramedic students, is and I see this with a lot of newer providers and new EMTs and stuff, that they'll hear the cool call drop. Where you're going is the call you're supposed to be on. When you get to that house, and whoever it is, that is where you're supposed to be at that moment. That is where your undivided attention should and will be, because a lot of people hear the cool call going down the road. It's no, this person that you're running on deserves 100% of your attention. They deserve 100% of your ability to do your job. And even when the patient says, "Oh, I'm wasting your time," no, never. No patient on the planet is ever wasting my time, ever. I am here to do this. This is the only reason why I'm here, is to do and treat you for what you're supposed to be, and to really convey that on to a lot of new providers. It's that is why you're here. That patient deserves, it doesn't matter if this is the 100th time they called, it's the homeless person that you have, or this person deserves your attention, your ability to be, and your full undivided ability to treat them.
That is a great point. I think
that's really awesome.
Too many people fall into that trap of, you hear the GSW down the road and you're going to a code 2 non-emergent stub toe or something, and you're so stuck on, I can't believe we're not running that GSW, and you don't focus on the patient who may have something actually going on, and you're going to miss it now because you're totally stuck in your mind.
And when I was a newer paramedic, we had a similar situation. This is why I really drill this home. There's a GSW that went down. I went to the old guy, or the 80-year-old lift assist, got there. This person was profoundly septic. Ended up having to do an epi drip. We ended up having to do a lot of stuff, and it was just really sold. It's you never know what you're walking into. So just be where you're supposed to be and enjoy every situation you're going to walk in. And so it's rough. Not every call is equal, but
I will say I'm a firm believer in what you said, though, is that's your call for a reason, though.
Yeah.
That GSW is that person's call for a reason.
Exactly.
You are where you are, and you get that call because, you're that appropriate paramedic that needs to be there.
I think I think people are put in your path for a reason.
Yeah.
And I firmly believe that.
Yeah.
And we've discussed that before as well. And I do think that.
Because
and I think you're absolutely right.
I can tell you, running a night, I ran 3 GSWs in one night because I was that person that was supposed to be there. And at the end of that night, I just wanted to cry.
Yeah.
And I couldn't imagine anybody else running those that were on that night. But, at that moment in time, I felt at the end of it, I was man, I don't know if I want to come back to this, but I was strong enough. I went home and I, had my coping skills, and the good coping skills. Yeah. and I couldn't imagine, a newer medic having to deal with something like that. And you're exactly right. You're on that call for a reason. Yeah. You'll get those calls. And I always tell people too, that's another thing with new medics. I'm don't wish for those bad ones. If you want to be in this career for years on end, you'll get those ones, and then you'll wish to never get them again.
Yeah, it's the same 100%. With nursing. You don't always want to be working the trauma. Sometimes it's nice to deal with the medical patients.
And sit there with the old lady,
Sometimes it's nice to just get the renal dialysis patient upstairs and get the person who has the cellulitis upstairs. You don't always have to deal with the GSW that came in or the stabbing, because the more you learn about it, the more you have to deal with it, the harsher it becomes.
The more you deal with it, burnout just so much quicker.
You don't want the high acuity calls all the time, because nobody can bear that either. I mean, if you're only running high acuity, that's going to burn you out as well. So don't get burned out by the non-emergent stuff. Use it as I can spend more time with this patient. I can get to know them a little bit. Yeah, they're not dying, but I can still get some satisfaction from this.
What's the good thing about emergency medicine is it does this. It's up, it's down, it's up, it's down. You get low acuity and you get high acuity. The good thing is that it's more low acuity than it is high acuity. And you're right, you couldn't have the high acuity all the time.
Well, what's that Bible verse that God won't give you more than you can bear?
Yeah.
I can't remember where that is in Scripture, but...
And you learn to appreciate the highs and the lows. When you've constantly had the lows where it's not much, you have all of that energy ready when that trauma comes in.
Right.
Then when you don't have the trauma anymore, then you're like, oh, good, I'm glad that I have my, appendicitis and my perfed bowels. Those I can deal with.
Right.
And then you have your stabbings and you're like, okay, now I'm ready for that. So it's nice to have those waxes and wanes and the acuity of patience.
100%. Anything anybody wanted to say that they had coming here that we didn't get to before we close out?
I love you, man.
I'm going to give it just a couple more seconds because I always ask that. Nobody wants to say anything, and sometimes people have something. Anything specific?
Not that I can think of.
Well, thanks for
I just appreciate you. I do. I really appreciate you doing this because I sit and watch these once in a while just to hear. I watched the one with Eddie, and I've known Eddie for a long, long time, over 20 years, and that was a side of Eddie that I didn't see, that I'd never seen before, and he had so much insight that I've watched it a couple times. But I just want to tell you that I appreciate you for this outlet.
No, thank you.
Yeah.
I think it's a good way to facilitate conversations we don't have time to have on shift. We just don't have time to really have genuine conversations, and this is just kind of a good way, I think, to facilitate it. So I really enjoy it.
Yeah, me too.
Well, thanks everybody for your time. I know everybody's super busy, so I appreciate you coming in on your day off to have some conversations, and we'll close out there.
Awesome.
Thank you.
Thanks for having us.
Thank you, guys.